Thank you, Dr. Tam. I would be talking about the corneal graft survival and IOP control combined in penetrating keratoplasty and pars plana amide implants. So these are little special cases where the pars plana, only the amide implants are being studied. I do not have any financial interest in any procedure or product. The purpose and methods to evaluate the corneal graft survival and IOP control after penetrating keratoplasty and pars plana amide glaucoma valve implant in patients with coexisting glaucomas and corneal disease. These were retrospective charts of 25 eyes, 24 patients that received penetrating keratoplasty and pars plana glaucoma implant simultaneously at Harkness Eye Institute from January 2002 to August 2009, so that's about over a period of 7 years. The mean follow-up was about 2 years, 2 to 106 months. Well, let's talk about some of the facts that we know about the coexisting disease. Uncontrolled glaucoma with severe corneal disease needing penetrating keratoplasty is complex. High IOP is not only threat to the optic nerve head, but also leads to endothelial cell loss and graft failure. Conventional filtration surgeries like trabeculectomies fail due to extensive conjunctival scarring in these eyes. Glaucoma drainage device with tubes in AC like the barbell is commonly done with a variable reported success rate of 48 to 92%, so it's very variable in the literature at 1 year, and 25 to 70% at 2 years. Tubes in AC, as we can imagine, can cause endothelial cell loss because of its proximity, and sometimes if they touch, they do more damage to the eye. And it is believed, it's just a theory, that the non-valved glaucoma drainage device like the barbell can have a tidal flow of inflammatory cells. When the tube opens, you can imagine that there would be some kind of a retrograde flow from the bleb on into the anterior chamber, and this can cause injury to the endothelium. So we wanted to see what happens when you use a valved glaucoma implant. The surgical procedure, as you can imagine, 3 things are being done simultaneously. It's a long surgery and you need a coordination of 3 surgeons at the same time. The surgery varied from case to case slightly, but most of the time it was done in the same fashion. It was started out by the glaucoma person, fornix-based conjunctival flap, FP7, which is the most commonly used amide glaucoma implant, suture 9 mm posterior to the limbus, tube cut with bevel facing posteriorly, just to make sure, or just to avoid getting vitreous into the tube, but usually that doesn't happen. And at this point, the surgery is handed over to the retina person. He does the 3-port pars plana vitrectomy. Removal of the vitreous base at the site of insertion of the tube is very important, so you try to make sure that he does the indentation and tries to remove as much vitreous, because these tubes, they'll look like a suckers. They suck out anything which comes close to it. So even if the vitreous base has a long strand, it can be sucked into the tube and can block it. Because these are sometimes failed corneal graft in which these surgeries are done, temporary keratoprosthesis had to be used in 5 cases with poor visibility to perform pars plana vitrectomy, and of course that entails more surgery and prolongs the time. Tube is inserted 3.5 mm posterior to the limbus. So after the vitrectomy has been done, the glaucoma person comes into effect again and puts the tube into the posterior limber through the 20-gauge asterostomy, the way it is supposed to be done. And the tube is secured, patch graft is placed, conjunctiva is closed. That is, the glaucoma surgery has been finished, and at this point it is handed over to the cornea person to do a penetrating keratoplasty. So it's a prolonged surgery and it takes 3 people to do it. And anyway, just to show you some of the results, the preoperative patient characteristics of this study were pretty much equal, female 14 and male 11. The mean age was about 79, and most of them were adults, most of them being white patients, and there were some black, Hispanic. The patient characteristics, the corneal indications were failed corneal graft in 16 patients, 16 eyes. Aphakic, pseudophakic bullous keratopathy was in 7 patients, band keratopathy in 1, and something else in 1 patient. From the glaucoma point of view, the IOP was mean IOP of 22 on medical treatment. Corneal angle closure glaucoma, you can imagine that these eyes have gone through some surgeries before. They have quite a bit of peripheral synechiae, and corneal angle closure glaucoma becomes common, maybe secondary to the various surgeries. Open angle glaucoma, pseudoexfoliation in 2, uveitic in 2 patients, and the other ones 4. As you can imagine, there have been operators, so the PS, the peripheral synechiae, were seen in about 23 out of 25 eyes. Previous glaucoma with surgery was in 13, and no glaucoma surgery in about 12 eyes. The Kaplan-Meier estimate of the probability of continued corneal graft success was at 89 at 1 year and 63 at 2 years. You can imagine as the time goes by, the corneal graft survival goes down. Intraocular pressure on the same basis was seen to be controlled 78% at 1 year and 44% at 2 years. The complication, in spite of everything done, the most important complication is the obstruction of tube, which was seen in 5 eyes. So it is very important that you do a good vitrectomy. And the other thing is graft decompensation. The last one that you see is in 9 eyes, and that also happens from various reasons. Other than that, flat AC was in 1, wound leak from the PK was seen in 1, hyphema in vitreous hemorrhage in few patients, few eyes. Comparing it to the studies in the literature, looking at, if you can see the first 2, the one which came out in 2010 had barbell only and also showed about 89% success at 1 year and 67 and 2 years out of 51 eyes, and we had pretty much similar. So the conclusion is that the valve does not make a difference, and when it comes to the corneal graft at 1 or 2 years. I do not know what happens after the second year. So the valve did not make any difference. But I believe an alternative to, instead of putting into the vitreous cavity, is to put the tube in the posterior chamber. And this is done easily. You can inflate the iris during the paracentesis, put some viscoelastic at the back of the iris, and then the tube, the way we do the tube in the anterior chamber, can also be done by making a hole into the iris and putting the tube into behind the iris in the posterior chamber. Thank you. Thank you very much.